Good morning, everybody. Can we get the slide on? Thank you. I would like to thank Dr. Raju Ishwaran, Dr. Maskar, and the Master Case Series organizing team for this honor to present in this wonderful gathering. I will present a case of a terrible triad of posteromedial tibia associated with ACL injury. This is an interesting case that we published in 2021 in JCOT. It has an ACL injury with bone injury, with ramp lesion and a double meniscal injury, defunctioning the meniscus and forming a terrible triad in the knee. We know that ACL is most commonly injured ligament in the knee, and it's associated with meniscal injuries and ramp lesion and other ligament, bone and chondral injuries may be associated. This case is a 24-year-old gentleman, an AC mechanic by profession, presented with instability of the knee of 2 years duration. A 10-foot statue of Ganesha, Lord Ganesha, fell on his knee and sustained this injury. And he's a fit and well gentleman. Examination of the knee showed no effusion, a positive Lachman anterior drawer and pivoting, no other injuries clinically, and has full range of movement. Radiographs showed early osteoarthritic changes, slight reduced joint space and osteophyte. There is a hint of bony injury of the tibial rim posteriorly. In retrospect, we could see a few findings in this X-ray: the impaction of the lateral condyle of the femur and the evidence of posterior rim of tibia. MRI scan confirmed fracture of the posterior rim of the medial tibial plateau, as seen in the sagittal sections, as well as evidence of injury to adjacent meniscus. So in our case, the following were seen: fracture of the posterior rim of the medial tibial plateau, ramp lesion, a double injury to the meniscus, which has resulted in an amputation of the meniscus. And these injuries are an avulsion of the posterior root and a complete radial tear. It's an oblique type of radial tear. So an arthroscopy was done, and the findings on arthroscopy: there was a ruptured ACL, a trans-notch view showing the ramp lesion and the contents within the ramp. The medial compartment was a little tight with loss of medial meniscus posteriorly. Posteromedial portal. This is the, you can see the contents. This is the posteromedial portal view. So this is the PM portal view showing the ramp lesion and the bony injury. And visualizing posteriorly, part of the meniscus, we can see there's a complete tear and missing meniscus medially. Very early changes in the cartilage, and probing and attempting to pull the pieces from inside the ramp, you can see that all the tissues have been clumped up together, and these have been removed. So those are the pieces inside. We cannot distinguish between pieces of bone, meniscus. I think everything has been adhered. So that was removed, and now we're making a second posteromedial portal to assist in removing the contents as well as repair. So the case I presented was a chronic 2-year-old injury. So if it had been an acute injury, what would be your line of management for the rim fracture of the tibial plateau? Can we have the second question, please? So in a chronic patient like this one, what would be your choice of management? After 2 years, you've seen the status of the tissues. Can we go for the next question, please? So how do you manage a meniscal amputation injury in an acute setting? Yeah, the meniscal tissue will be good, so assess and repair the native meniscus. The next question, please.
The next question.
Similar amputation injury, similar to a case you have seen here, what would be your approach? So others is an option. It would be an interesting option to discuss, actually. Can we have the next question, please? I think just 2 more questions, and we are done. So how do you manage a ramp lesion in an acute setting? Fix the ramp to the meniscus after the meniscal repair. Okay. And the last question, please. The 4th option is not reflected, but I think we can. Okay, so fix ramp lesion to meniscus after repair. Okay, we'll move on to the presentation. So in this case, we used a first pass suture. At that time, the meniscal autograft transplantation was not very popular. Fiber wire sutures were passed into the ramp at 2 separate points. And the first point was shown. This is the second point. And you could see that as we pulled the fiber wire, the ramp was reducing. A bead pin was passed from anterior and over-drilled with a 4.5 drill bit to create a tunnel. And a suture shuttle was then passed from anterior to pull the fiber wires out through the tunnel. So the meniscus repair was not done at that time. So what I did was to fix the ramp to the bone, creating a bony bed for a possible meniscal transplant later. Actually, this injury was not detected at the time of, in the radiology opinion. So we could see that once the wires were pulled anteriorly, the ramp reduced well. This is a post-operative radiograph. We can see some irregularity of the posterior tibial rim. And this radiograph is at final follow-up at 2 years, 8 months. We can note the increase in the osteophytes in medial compartment and decreased joint space. The button was removed about 8 months post-operatively. He had some symptoms. And this is a follow-up video at 2 years and 8 months. He's mobilizing well with full range of movement. He was offered meniscal transplantation, but he refused to take it as he has no problems with his knee at all. He's functioning well without any issues. The components of the injury, as you have seen, ramp lesion, which was repaired, root avulsion and amputation of the meniscus, which would ideally need an autograft, allograft, or a synthetic graft, and a posterior rim fracture of the tibia. So the ramp lesions have been classified as stable and unstable. As we know, a more anatomical classification was done by Thornett et al. And the key is to fix the unstable types of the ramp to stabilize the meniscus. And the risk factors include bone marrow edema, contact injury mechanism, concurrent lateral meniscus tear, revision ACLRs, and age less than 30 years, and chronic ACLs. We asked Thornett and colleagues of their opinion on the associated bone marrow edema in lateral femoral condyle along with ramp and regarding the mechanism. The response is that it is unclear, still unclear what the exact mechanism of ramp injuries are. And there are multiple theories that have been discussed in this letter to the editor in AJSM. And I would recommend the esteemed speakers and delegates and the viewers to read this response for a better understanding. And they point basically towards the active contraction of the semimembranosus and its resultant forces as a prime factor. And posterior root avulsion of medial meniscus falls under type 5 of the classification of Laprade et al. And root avulsion with concomitant ramp injury has been classified by Dr. Sheetal Gupta recently into type 7A, and loss of substance of root injury has type 8 in a recent new extension of classification of root injuries. And these two components are present in our case. In addition to this, although bone marrow edema of posterior tibial rim has been reported in association with ramp lesions before, there was no report of fracture of the rim in association with meniscus and ramp lesions. In response to our letter in AJSM, Tonat and colleagues responded that in their series of 2,000 odd cases, they did not find a Contrecoup type of bone marrow edema in the lateral femoral condyle in association with the ramp lesion. So it appears that the rim fracture etiology is unclear but related to semimembranosus contraction, consequently perhaps to traction injury by the meniscotibial ligament, given that there is no femoral-sided impact. Nevertheless, it would appear that the injury is still unclassified and would perhaps fit into a new type 9 or isolated rim fracture, and type 10 for a combination of injuries, the triad. We have actually written this to Arthroscopy Journal about this in a letter to the editor, which has been accepted and hopefully published soon. So our case has implications in classification of ramp, meniscal root, and meniscal tear types, and it adds a new dimension to these injuries, and it ties all these injuries together, and it extends severity of injury of these structures to a new level. And it raises a lot of questions in managing such injuries. Multiple challenges.
I think it's a good case, very means rare as well as difficult to manage. I just want one simple thing, means what were the main complaint of this patient? Whether it was an instability or pain, both, and if pain is, what character of pain? And what were the relief in symptoms after these 2 years follow?
He came with instability as a predominant symptom. He did not complain of pain at that time. He was 2 years post-injury when he presented.
So do you think all these ramp repairs have helped in getting the instability part better, or means?
I think so. I think ACL reconstruction combined with this ramp repair, although ramp is not the repair we have done is a capsulosynovial repair. It's not as sturdy, but ACL in combination with that repair must have helped.
So what type of instability? It was pure ACL, or was there some sort of?
It's pure ACL reconstruction.
Okay. So you think that if that was a responsible lesion, it should have given some posteromedial or some sort of a rotatory instability along with ACL? Otherwise, probably the results would have been same if you do just ACL reconstruction. Means how we correlate that with this?
On examination, he did not have other rotatory instability. Posteromedial corner and medial side were intact.
Okay.
Almost 3 years. Almost 3 years now.
And the arthritic changes have worsened over time, you mentioned.
Yes, like the joint space has decreased, and we could see in the last X-ray that osteophytes have developed, have increased compared to.
What I was wondering, if you would have not repaired the ramp back to the bone, or if you have left it as such, just removed and debrided the components, would the wear out of the joint be any different? Would it be faster? What did it add to the outcome of the patient?
Our idea was to transplant the meniscus as well in a second sitting, because at that time we had not expected this, because the report and MRI scans were not clearly showing. So after he recovered from ACL, we thought we will do a meniscal allograft or a synthetic, because the patient is from low socioeconomic status. Synthetic was out of the league, and meniscal allograft was an option. Meniscal autograft was not very popular at that time. That would probably be a good option currently, but he is happy now. He does not want anything done. I think adding a meniscal reconstruction or transplantation is the key to prevent the osteoarthritic changes.